All right, incentive matters. So good morning, all. So I'm here to talk to you at the Reimagine Aging Conference about how the power of incentives and follow the money. And if we adhere to some basic principles, we're going to be able to improve care for seniors in British Columbia. And first of all, I want to talk about the fact that incentives matter. And if you have any doubt about that, just think about your own personal behavior and how you respond to incentives. When something is 2 for 1, you'll buy 2 of them. When there's a discount at one store and full price at the other, you'll go to the store with the discount. When you're choosing where you're going to buy your goods or what airline you're going to fly on, all these loyalty programs, they're out there for a reason. They do influence our behavior. Incentives matter. We may love our jobs, but we have an amazing capacity to convince ourselves that we love the job that pays more. And so on and so on and so on. In healthcare, we often don't like to recognize incentives because we like to believe we are called for a higher purpose, that we are here to serve others, and that's our primary focus. But in the end, all of us respond to the incentives in front of us. What's different incentives will elicit different responses in different people. That's true. But these incentives matter, and they matter in healthcare, and they matter whether it's publicly funded healthcare, privately paid for healthcare, privately delivered, publicly funded healthcare. These incentives matter for us as patients and consumers of the service and as providers of the service. And what we've got right now in British Columbia, particularly, and arguably in Canada as a whole, is a misalignment of these incentives. And it's causing some, not all, but some of these disruptions and some of these stresses that we are seeing and challenges that we are seeing in our system. And we've got to acknowledge these, and we've got to make these work more effectively for us. And if we do that with the end goal, what is best for the senior, which ultimately is what the senior wants for themselves, not what we want for them, what they want for themselves, then we will improve the lives of seniors in British Columbia. So next slide. Okay, so let's just talk a little bit about what are the current incentives that we have in our healthcare system. I have to look at the slide, so I got to stand over here. First of all, we incentivize healthcare in many, many ways. First of all, rationing and budgets, which we do in British Columbia. So we will ration our scheduled procedures every year. We will say, this is how many scheduled hips and knees that we're going to do. These are the numbers of scheduled procedures we're going to do. And that's one way that we're managing the system. We also manage the system through capitated budgets. We will make people wait for things because we've spent the budget on that for the year. This is in our public healthcare system. So we need to acknowledge that this is what is happening and is in part driving some of our wait lists. We ration our long-term care beds. So if we look at the waiting list for long-term care, basically it's because we've said this is how many beds we have. And every year we decide how many more beds, if any, we're going to add to the system. We have incentivized the behavior of the system by rationing the availability of long-term care beds, the same with assisted living, publicly funded assisted living units, and with our publicly funded home support hours. That's how the public system deals with incentivizing the behavior within our healthcare system for these things that seniors need. If we look at how we incentivize public care delivered by the private sector, so technically not-for-profits are the private sector. The government says this is a service that government is to deliver, but we are going to ask the private sector to deliver it on our behalf. We do it in healthcare, we do it in a whole bunch of other things. So how do we incentivize the private sector to deliver the public goods that we want? Well, output-based. We will say to a private surgical unit, we will pay you to perform 1,000 endoscopies for you. We will pay you to perform cataract, 2,000 cataract surgeries for us. So it's output based. You perform the procedure, we will pay you for it. Performance based. So sometimes the incentive will be not just your output, not just the numbers, but the performance. So did you do it well? What is the satisfaction of the people who used your service? Did you do it on time? Did you manage? All of these are performance-based incentives. And when you tie them to the funding, you will get the performance from the provider that will maximize their ability to leverage these incentives. So we can make it output-based, we can make it performance-based, and lastly, we can make it price-based. We put out an RFP for a widget, we give design specifications for the widget, and we take the lowest bid that will meet the specifications of the bid. That's the other way we incentivize the behavior. Consumer behavior. Healthcare is delivered to consumers. We can call them patients. In acute care, we call them residents in long-term care. We call them clients in home care. But they are consumers. And how do we shape their behavior? Cost. What do we charge for? What do we not charge for? Very interesting when it comes to seniors care. Because for people who aren't seniors, the idea of the cost of healthcare is zero. We don't pay to go to the doctor. We don't pay to go to the emergency room. We don't pay to get the x-ray. And that is mostly what younger people have as their experience with the healthcare system. When you're a senior and you need long-term care, we charge you. You need home support, we charge you. You need incontinence supplies, we charge you. And the list goes on, right? So there's a bit of a wobble there. The other way we shape consumer behavior is convenience. What do we make convenient for somebody to use? What do we make it inconvenient for them to use? And people will make choices. It's amazing how something is absolutely necessary until it's inconvenient for me to do it. And suddenly it's not so necessary anymore, right? And people will make these value judgments around what is convenient and what is not. And an example of that are some of the measures we took during COVID, where if we use surgical wait lists, for example, where surgeries were canceled, they were rescheduled, people were phoned back. Suddenly, some people weren't going to have the surgery any longer, right? Part of the way we cleared our surgical backlist was all of the people scheduled for surgery, actually not all of them opted to have the surgery when we re-engaged with them. So and preference and choice is the other way. And that is completely missing from healthcare in British Columbia and in Canada, arguably, for better or for worse. In the old days, at least you could choose your doctor. You can't choose your doctor. You can't really choose what hospital to go to. In policy, you can choose the care home to go to. In practice, most people, when they're in the circumstances of needing a care home, take the one that is available. And most particularly, even the choice is not open-ended. We give you the list to choose from in your care home. So next slide. So what are the challenges in aligning these incentives to get the outcomes and the behaviors that we want? First of all, there's no choice. Most systems are designed, the free market will talk about, you need competition, because competition will raise the standards. Why? Because there's choice and people, okay. None of that applies because we don't have choice in our public system. And who pays? The consumer or the government? One of the things we don't talk about in Canada with our public healthcare system, which has many, many benefits, but think about this inherent conflict of interest. The person paying for the care you are going to receive is deciding what care you will receive. Think about that for a moment. So when we talk about how we ration procedures, all of these other things, these decisions are being made for you, who is the consumer, but you're not the payer, right? So it is the government who is deciding what it is that you will receive and how you will receive it. Incentives align in British Columbia more so than in other provinces, but not other provinces have this challenge as well. Our incentives align to favor long-term care over home care, both for the consumer and for the provider. And I'm going to talk about that in a minute. So what we need to remember is most of us want to live in our own home for the entirety of our life. And the good news is actually most of us overwhelmingly will live in our own home for the entirety of our life. There will always be people for whom long-term care is the only option for a variety of reasons. That the idea that we can eliminate long-term care and have this utopian world, I think is a rather naive notion. So there's always going to be a need for that. But what we need to ensure is that for the senior, for the consumer, we have exhausted the options for them to be able to live as they want before they enter long-term care. It will make managing long-term care, working in long-term care, and living in long-term care a better experience if the people there can understand that other options have been exhausted. It must be very, very frustrating for somebody to be in long-term care who, number one, does not want to be there, and secondly, probably could be at home if we had better aligned things. And I'm going to talk a little bit more about that. And then the last challenge is that the incentives in our funded long-term care system in British Columbia are not aligned to achieve maximum value for our dollars. Okay. So next slide. So in British Columbia, and I've been banging on about this for quite some time, and I'm going to continue to bang on about it, we charge for home support. Most other provinces actually do not charge for home support, right? So think about that. Most provinces do not. If you live in Alberta or Ontario, you pay nothing for your home support services. If you live in British Columbia, you pay, and you pay a lot. So if you are a senior on the guaranteed income supplement, which is 30% of our seniors in British Columbia, you do not pay. The 70% of our seniors, however, who are not on the guaranteed income supplement, do pay for their home support. And what you pay depends on your income. So I'm going to give an example. I have to pick an income. I have picked the income of $29,000 a year. This income is unfortunately more representative than we would like to think, right? The median income of a senior in British Columbia is about $33,000. So $29,000 is the experience for many seniors. So you can see the column, home, long-term care. So if your income is $29,000, you do pay a little itty bitty bit of tax. So you're netting out at $27,900. So a person on $29,000 a year, their client contribution for long-term care is going to be $22,300 a year. If they live at home and receive 1 hour a day of home support, 1 hour a day of home support, and their income is $29,000 a year, we are going to charge them $9,000 a year for their publicly funded home support. I want you to let that sink in. On $29,000 a year, their daily rate for 1 hour a day of home support is $9,000 a year. They still have to pay either rent or electricity bills and maintenance and all the rest for their housing. They have to pay for their food. I suspect that's higher. They have all their other healthcare expenses to pay. Their drugs aren't covered. They won't pay a lot at $29,000 under Fair Pharmacare, but they're still going to have to pay for some of their medications, all their over-the-counter stuff, their clothing and personal supports, their telecommunications. It's $1,200 a year just to have internet and a phone, right? So their total expenses exceed their income. They're $11,700 in the hole. If they move into long-term care, they've got $2,000 extra. Their annual cost savings to go into long-term care versus stay at home is $13,700. That's the system that we've got here in British Columbia. And we need to think about that. So next slide. The system is also not being effectively maximizing its ability for value to the taxpayer. So if let's say we remove this daily rate from home support, okay? What would it cost? It would cost this $29,000 a year person. It would cost us $14,100 a year to provide their home support. Instead, what are we doing? We're paying $59,900 of taxpayers' dollars to place them in long-term care. They are paying the other $22,000, right? But that's where the incentives are not aligning. And not only is it poor value for the taxpayer, it is not what the senior wants. So how does this play out? Next slide. 61%, 6 out of 10 new admissions to long-term care had no home support 90 days prior to their admission. And I want that to sink in. You know, you're not living at home totally independently with no help, and then suddenly overnight you go to total care at long-term care. No. That's not the way I mean, there'll be catastrophic strokes and car accidents that will cause, but that's a very, very small percentage of our long-term care residents. Most come into the system after a graduated period of increasing frailty and dependency, but they're not getting home support. Now, they're not getting absolutely no support. Family, exhausted, overburdened, in crisis, family members who are at the end of their tether. And I don't know who in the room has dealt with these families directly, maybe most or all of you, as I have, and I know some of you have, and met them. And you just have to wonder, if we provided them with a little relief, maybe we could have prevented or delayed this admission, and it certainly wouldn't be the crisis admission that we're dealing with. Now look at the chart on your left. So Kai does this calculation of, for want of a better term, low care needs people in long-term care. So these are people in our long-term care settings who, when we look at their inter-eye data, we realize actually they could be supported at home with some supports. They could absolutely live in assisted living. Not all of them. There'll be other circumstances that will place them in long-term care, but certainly a proportion of them would have been able to stay at home. In British Columbia, we have twice as many low care needs long-term care residents as they do in Alberta and Ontario. What's the difference? Home support's free in Alberta and Ontario. So I know the government, they're running around. Okay, Alberta and Ontario provide home support free of charge. Last time I looked, neither of those provinces had completely collapsed. I know we have our opinions, but at the end of the day, they're chugging along. So it is clearly possible, as it is for the majority of provinces in this country. And the evidence is absolutely overwhelming. We are prematurely placing some, not all, people in long-term care. And then care operators will, well, there's nobody in my facility who doesn't need to be here. Actually, there is. But the thing is, it's 13%. I mean, if you have 100 beds and you have 13 people who really you're not going to notice them. Let's be honest, right? You're going to think all your residents need to be there. But we know the data don't, and the data are consistent and they're comparable and inter-rater reliability and all the rest of it. It's the same assessment. The body is aging the same in, Coquitlam as it is in Canmore, Alberta and Colville, Ontario. We don't age differently. So what's the difference here? I can't afford to stay at home and get this home support. And it's a daily rate. So what you see sometimes is people won't take it every day. They need it every day, can't afford it every day, right? So you see it every other. And when you look at when you look at the numbers of our home support delivery in British Columbia, and I won't get into that, that's a whole other issue, and your long-term care, I respect that. The amount we're providing is insufficient, even to the ones. And the other indication that incentives matter, 70% of British Columbia seniors have to pay for their home support. 70% receiving it don't pay, which is what the minister keeps talking about. And that's true. But that's because if you have to pay for it, you don't get it. It's not this, there's not this good news story, 70% of the people getting home support don't pay for it. Forget about the issue is 70% have to pay for it and they're not using it. Right? The people with lots of resources, they're actually being taken care of. It's the people with modest incomes, which is actually most seniors in British Columbia, right? So now let's look at how we've misaligned the incentives in funding for long-term care. So next slide. So again, I've been banging on about this and I will continue to. So what you're seeing here are real financials of two real care homes in British Columbia. And you can see, as you may know, the way we fund long-term care in British Columbia is that we have what's called a per diem. So we say to care home operators, we add up what we think they should spend on everything, and it spits out to so much per bed per day, and we give them that amount of money. And if they don't spend all that money, they can keep whatever's left over. Why? Because we have no line called profit. It'd be more transparent if we did, right? So if I am a care home operator, the only way I can get my profit is to not spend as much on these things that we think you should be spending money on, which is how we've come up with your per diem, right? So here, these two care homes, by the way, have exactly the same per diem. Okay. So total revenue for one is 17, I'm going to use round numbers here. One of them is, they're both around $18 million, but their expenses are very different. The expenses in the for-profit are only 15 or 16 million, and the expenses in the not-for-profit are actually more than their funding, over 18 million, right? So the profit care home has basically a $2 million a year profit, and the not-for-profit's in the hole by $500,000. Now, here's what's interesting. See the profit in the care home that is the for-profit one, the $2 million? That comes after we've paid out 2.6 million mortgage and principal on a building the public doesn't own, after we've paid repairs and maintenance on a building we don't own of $500,000, after we've paid $500,000 in a management fee, on top of administrative support of $500,000, managers, and their audit and insurance. That's after we've paid all that. And of course, the wages for the staff and the food and all of that. But all of that, after all of that, they still, now let's look at the not-for-profit. They got $100,000 towards their mortgage and interest for a building that's owned by a society. They don't have any management fee. To be fair, they have more administrative support. And they have more support and food services, et cetera, right? So how are we incentivizing the long-term care homes to spend the money where we want it to be spent, which is on the service to the people living there? And everybody in this room knows your experience in long-term care is based on the people you interact with, on the food you eat, and on the engagement you're able to experience in that care home. Frankly, it's not really about whether the paint on the wall is the latest color and all of those kinds of things that we all like to think. When you're living in long-term care, that isn't what is shaping your day-to-day experience. Next slide. So what we find is in this current funding model that we have for long-term care, not-for-profit care homes spend $10,000 more per year, or 24% more per year on each resident than for-profits do. Right? Each resident, not in total, each resident every year. The for-profit care homes failed to deliver 207,000 hours of funded care, because we let you keep the money. We say we don't, but we do. And the not-for-profits delivered an additional 80,000 hours to what they were funded to deliver. Incentives matter. We will respond to the incentives in front of us. How we respond and which incentives will be different, but they matter. And the way we are funding our long-term care in British Columbia, 2/3 of it is contracted out, is not maximizing the quality of care for residents or the benefit and cost effectiveness to the taxpayer. Next slide. And the bizarre thing is how we're dealing with these per diems. So, you know, it would look one way if the lower per diem care homes were producing the profit and the higher so you would say, okay, well, we're funding the ones that need it more and not funding the ones that clearly need it less. No, we haven't got that right either. We're paying the highest per diems to the highest profits and the lowest per diems to the losses. So you've got these poor schmuck care homes out there, for want of a better term. I suppose I should find a more delicate term. You know, look at the one that's, you know, losing $145,000 a year or only making 38. Look at their per diems are all under $200. Now, these data are all a couple of years old, but it would be grossed up. The magnitude would be the same. But look at the per diems of the ones at $2.7 million profit and 1.2. All those per diems are $220 or over. It's misaligned. And the people that are paying the price for this are the residents, right? So the care homes with the low per diems, most of them, even with their low per diems, are putting it into staffing. But there's other areas that they're not able to fund. And the ones that we're paying more to are putting less money into the residents. And I probably should let questions happen, but I just want to follow on the speaker that preceded me about outbreaks in care homes and another aspect of all of this funding, because even when we fund you for care hours, we'll call it 3.36, we don't specify and hold you to how many hours you allocate to registered nurses, to LPNs, to allied health, et cetera. A surprising number of care homes in their budgets have no expenditure for allied health, which invites a whole lot of questions, but we'll put that aside for a moment. When we looked at COVID outbreaks, so we examined the data from every outbreak and, you know, what would fuel an outbreak to spread, right? Because whether or not you had an outbreak was for the most part out of your control, since one case in the beginning would trigger an outbreak, right? So we said, okay, what is that question here is, how were some care homes able to contain these outbreaks? How were other care homes? One of the most significant correlations to containing an outbreak was a high ratio of registered nurses. Okay. Now that makes sense intuitively, because as a registered nurse, you've had training in acute care, you have likely been on units where there's been infectious disease outbreaks, you know how to do proper protocols for infection control. LPNs, not so much necessarily, right? So then when we looked at who has RNs and who doesn't, and even I was surprised at the magnitude of this, publicly funded sites allocated about 14%, 12 to 14% of their staffing allocation was registered nurses. In the publicly funded but privately run care homes, it was 6%. Half. Let that, right? Incentives matter, right? An RN costs more than an LPN. And you know what? I am as guilty. I've spent my whole life in the public sector or not-for-profit sector. But even I can remember probably 3 years ago, the argument, we can't find an RN for overnight coverage. Couldn't find one. Well, we'll have to put in an LPN. Yeah, okay. And then we realized, oh, hey, we put an LPN in and the world didn't fall apart. Hey, you know what? And it's a lot less expensive. This is actually, right? Not, okay. And so I jumped on the train with everybody else, right? A lot of times we make decisions today, we don't understand the consequences until it's 25 years later. You don't notice the lack of an RN on a day-to-day basis. You notice it when there's a crisis. That's the issue. There's not a crisis every day. So on a day-to-day basis, yeah, I can muddle through with my LPN. But when a crisis hits, and you might go a year or 2 years or 3 years without a crisis, you don't notice what the value is of that higher level training and thinking. And we saw it very clearly in COVID. So, I often wonder, what decisions are we making today that aren't going to look so good in 25 or 30 years? Because I can think of a lot of decisions I made 25 or 30 years ago that don't look so good today. But that is one of them, right? We have rationalized for a whole variety of reasons why we've been reducing the RN coverage in long-term care. And I'm as guilty as the next person, right? But I think we have to step back and take a look at some of this evidence and take a look at how we are incentivizing things. Next slide. So if we align incentives to leverage the best of all of our systems, this is not about let's get rid of private long-term. This is not about that. We don't have to do that. We just have to align the incentives to provide the outcomes that we want. We will get better outcomes. Client preference will, interestingly enough, be better met. And it will be better value. Though just realigning even within the current money, and we are going to have to spend a lot more money, but that's another issue. But even just realigning what we have, we can improve it. We can have better outcomes. Clients will get what they want, whether they want to be at home or how they want to live in long-term care, and there will be better value for the public who is paying for all of this. That's all of us. And with that, I think I'm going to take questions.